Saji, can we start? Already seven.
Yep.
Yeah. So, dear friends, we are starting today's session. So, I'll be just giving you an overview and again a few topics. Actually, some people asked me to discuss. This is today's figure. Like we are almost reaching 22 lakhs with 1 lakh 40,000 deaths and 8,000 people are very critical and almost 3 lakh 28,000 people have already recovered. So the US, the cases are creeping up like anything. They've crossed 7 lakhs today with 37,000 deaths. At the same time, China had only 82,000 with 4,600 deaths. But at the same time, you have to remember this is the reported case. We don't know what has happened there. UK has crossed 1 lakh, and France and Germany nearing 1.5 lakhs, and other two countries are nearing almost 2 lakhs. And here in Japan is again increasing the case. That is the two things we observed last few days. Singapore and Japan, they have almost contained the disease, but both the countries are showing an increasing trend. Korea is also the 10,660, and Peru, Israel, Sweden, and India. Like we are in 24. 19th position now. Again, the cases are increasing in other countries as well. Belgium, Russia, Turkey, Iran, all those. Iran is almost stabilized. That is the situation today. In India also, we are nearing 15,000. But the doubling time is not that scary when we are looking. Like uh, cases are increasing. Definitely, we have to contain. We have not plateaued, but still, it is not alarmingly going high when you compare with other countries like other European countries or US. I think still we are under control. Maharashtra, like little bit out of control with 3,300 cases. Delhi not creeping up too much. Madhya Pradesh 1,300, Tamil Nadu 1,300. Tamil Nadu also the cases are not creeping up very fast. Rajasthan there is an increase but not very fast. But Gujarat has really lost their control. That is the reviews coming from all parts of the country. The Gujarat is likely to get affected badly. UP, Telangana, Andhra Pradesh, all these states are UP, I don't know, but Telangana, Andhra Pradesh, and Karnataka, especially all South Indian states are uh, really doing a good job. Even though the case numbers have gone up, but still the containment activities and their involvement is really commendable. So this is like in comparison with other places, like as we were discussing all the days, we have really plateaued the curve. But other like except Maharashtra, other places are also like almost showing a trend of touching line. India, but unfortunately, still it is creeping up. The case trends also almost plateaued, not creeping up anyway. So last 3 days, I think we can take it as a positive trend. Maybe by May 3rd, we also will plateau that. This we have reached with 395 cases and almost plateaued in Kerala. With active cases are really declining and almost touching to the baseline. So with four cases today, we have reached 395 as on today, with 140 active cases in the hospitals. And out of this 395, 272 are imported cases, and only 123 secondary cases are affected from here. So this is a one people are asking me to discuss. Like this is almost 20 days or like 21 days over, 3 weeks over. Still, how these people returning from Dubai they are getting infected? Is it really an increased incubation period, which like force us to think we will have to increase the incubation period or the quarantine, not the incubation period? And here, this is the other good thing in Kerala. We have exceeded the active cases in terms of recovered patients, and the death is only two. In Nizamuddin belt, it is same 550 persons attended, 130 returned, and 18 affected. So today, the initial one I'm going to discuss is about this drug tocilizumab, which we were discussing few days before. But last few days, like when we are having a discussion over the like especially in the national level, those who are having a cytokine storm, majority of the people have started using tocilizumab. So you should have a basic idea about tocilizumab. I think the previous sessions who have listened to me, I've given you an overview, but today I'll try to go little bit in depth about tocilizumab. So this is basically an ILR6 antagonist, a monoclonal antibody. This is binds to membrane-bound and soluble forms of interleukin-6 receptors. You can see there is an area where this interleukin-6 receptor is blue, where areas are bound. So these molecules will bound to that area. There's tocilizumab. You can see this will be binding to the IL6 receptors and prevent binding interleukin-6 to the receptors. So this is basically in the site in case of a cytokine storm. So this is an immune response in viral infection. It is not a new concept. We know that the cytokine storms or the macrophage activation we have seen with many other symptoms. The previous coronaviruses also, especially SARS and MERS, also had cytokine storm. A recent study suggested the same may be true in COVID-19 infections as well. So everywhere the people were observing that. Today we had a meeting with Chinese doctors. So they were also told that they also observed that. So now what data we have in terms of tocilizumab? Like this is a retrospective study which evaluating the efficacy of tocilizumab in treating severe infections. They were studied 21 patients in this article, where like the inclusion criteria were when the patients were having a tachypnea, a low saturation, and like ARDS range. You know that PF ratio when it is less than 300, we call it as an ARDS range. The critical things were considered were mechanical ventilation, shock, and organ failure. So they used 400 milligrams of IV dose. The tocilizumab is freely available in India. Many companies are producing. So the cost for 400 mg is somewhere around 30,000 rupees. We have 80 mg and 200 mg preparations as well in India. So here all patients received the SOC means standard of care for at least 7 days prior to the tocilizumab, but these people were continued to have sustained fever, hypoxemia, and and CT worsening. So here the IL-6 were measured by electrochemical luminescence with a reference value of less than 7. So IL-6 values are referred in many places. Same way you can look at soluble CD24 also. So here in 81% of the severe and 19% of the critical. So the baseline elevation seen in CRP and mean IL-6 levels. So here in these group of patients, you can see the body temperature normalized within 24 hours, and 75% had lowered their oxygen intake or their oxygenation has significantly improved, and almost 90% of patients had a CT improvement. So with that, we can conclude the tocilizumab, even though it's a 21 numbers only, appear to improve clinical symptoms in patients with severe critical COVID-19. So even though like we are not putting all patients on tocilizumab, especially when you have evidence of cytokine storm, which we have discussed few days before, that's why I'm not adding that slides again. There is something called H score. Those who have not attended that class, there is something called an H score, so freely available in the net. So in the like with the H score, you look at the fibrinogen level, you look at the liver enzymes, other parameters ferritin value, triglyceride value, and the cytopenias, the number of cytopenias, whether they are having or immunosuppressions. Based on that, you will get a score. If it is more than 169, possibly the patient will be having a macrophage activation syndrome, or nowadays we call it as macrophage activation like syndrome. So those group of patients, those cohort definitely are going to benefit with that. So what are the limitations of our present data? Like the randomized control trials results are not available at this time. We don't have an RCT. Uh, we still do not understand the complex nature of the immune response. Like exactly don't know, because there are so many theories, microthrombe, microembolism, all those things. The cytokine measurements in peripheral blood may not correlate with the immune response in deep tissues. This is the other problem, because in sepsis also we were studying IL-6 values and the cytokine removal and all. But majority of the time, even when we get a significant IL-6 reduction, that was not getting reflected into the clinical outcome. So here also we will have to wait and see, even if you reduce IL-6, whether it is going to clinically benefit or not. The link between cytokine response to therapy and disease outcome is not well understood. We don't know that. I've already told. Then again, there's still a question whether the like retrospective study by these Su and colleagues. Again, like we will have to analyze in detail. It's not very clear. Use of tocilizumab therapy is not without risk. Definitely, the secondary infections will be high. So the dosing is basically, I've already told, 400 milligram IV once, that is a dose, or less than 30, you can give 12 milligram per kg, or more than 30, 8 milligram per kg to the maximum of 800 milligram. Like majority of the time, 400 milligram as a single dose, a repeat dose for patients with a persistent fever. So the repeat dose, the purpose or that practice is not routinely done. And here again, the recommended dose is 400 milligram, that you will have to dilute in 0.9% of saline in 100 ml and infuse over 1 hour. And again, as I've told, you can repeat one dose depending on the symptoms, but not more than 800 mg even in that case. The adverse reactions are like, especially when the patients are immunocompromised or the secondary infections are likely, especially in a cytokine storm, like a viral syndrome situation, patient already in the ICU, reactivation of latent TB. The Canadian study has told like a liver injury, the liver enzymes elevation, especially like liver enzymes more than twice. And the initial dosing studies like have shown the neutropenia, that's very low, not very high numbers. Lack of association between neutrophil levels and infection rate. This is also where, like we were to always keep in mind when treating the patients. Don't think that increased neutrophil counts are always because of infection. There are many other reasons as well. Then the drug interactions, like especially immunosuppressants, including other disease-modifying anti-rheumatoid drugs and tacrolimus. So these all can the combination with other drugs. So we'll have to think about those drug-drug interaction. Then again, cytochrome like activation, like tocilizumab may decrease the serum concentration of CYP3A4 substrate, and blockade of IL-6 may enhance CIP function. So you will have to always think about these drug interactions. So the clinical pearls are the criteria for use and resource limited settings. Maybe you can, I've already told you, go for H score. There are other scores like Penn scales, Lee scales, CTA, CAE criteria, etc. So at least this H score is very simple. Then availability and turnaround time of IL-6 level, which will be more than CRP. And again, majority of the places we don't have IL-6 values as well. The rule out latent TB, obviously. Monitor other drugs I've already told. Dosing, flat dose versus weight-based repeated doses. But I think in Indian scenario, going with a somewhere like a flat dosing, when it is exceeding 400, also you give 400 milligram. The cost also you can save. Then optimal timing of administration is really exactly, we don't know at what point we will have to give tocilizumab. So there are many clinical trials going on, which we will not discuss at this point. So coming to another area, this is a one which we all have to think in depth. See, like this is the detection results of clinical specimens from the JAMA trial. Here, see, this is the positive test results. So the ball fluid, that is a bronchoalveolar lavage fluid, in 50 number of patients had shown 93% of heal, but the breast biopsy only 46, sputum 72, the nasal swab or nasopharyngeal swab is 63, but the pharyngeal swab is only 32. So I was discussing with many doctors here in Calicut and in Malappuram district. So still we are following the pharyngeal swab. It is high time that we have to change into nasopharyngeal swab again, which we have already shown you. We have to bend the neck of the patient a bit. Then you just pass the swab by touching the floor. Then once you hit the nasopharynx, You keep rotating it for 15 seconds, then you take it out. So that is the way you have to take, and it is a flock swab that you have to use. It will be something like a brush. And again, whenever possible, you go for nasopharyngeal swab. And if you are really in doubt that the patient is clinically an intubated patient, clinically showing like a significant radiological findings favoring a COVID, but your repeated PCRs are negative. So even though the ball is an aerosol generating procedure, that may be the best way to exclude, I feel, but still a debatable issue. I won't recommend doing ball, but in that doubtful case, especially when you have a negative pressure isolation room and like the proper PP, etc., I think that is we can consider doing a ball as well. This is again like the cycle threshold, and the patient like as the number the days advances also, you can see uh, the positivity, the pharyngeal swab followed by the nasal swab. So nasal swab is always having a like a better positivity. So, this is how you have to do the surveillance. There will be an incubation period. So, in that time, you will be monitoring the contacts. This person may be a contact. You may be screening an asymptomatic contacts also with a PCR test. Here, you will be screening the symptomatic contacts, diagnosis, and the treatment initiation and decision. Then followed by de-escalation, monitoring of shedding and convalescence. So, monitoring of shedding. This is the point where the people are getting confused now, because as per the present criteria, we have to get two negative samples before discharging like any patients. So there are many patients who are getting the persistent positivity. So today one paper has already been published which has shown that there may be up to 58 days, one case they have already reported, where the person has a persistent PCR positivity on an average 20 to 24 days. And again, it is not very rare to have a positivity up to 40 days. So that is the situation. Now the question is, we will discuss that in later. Even if the PCR is positive, that doesn't mean that the patient may be like infectious, because the PCR, we are testing only the viral particles. That doesn't tell you that that is a live virus. So obviously in such cases we will have to get a viral culture done, but in an Indian scenario that is difficult. Even in other countries also, they have not done the viral cultures very routinely. This is also like few doctors requested me to discuss about this thing. Like few days back, we all have seen in like newspapers and media that Srijitra has developed a new technique of PCR or a viral detection. So what is that? So this is otherwise called a LAM technique, and this is the reverse transcriptase PCR. So here again, you have to see many people are mistaking, don't know what is this RT-PCR. This is not the real-time PCR. This RT stands for reverse transcriptase PCR. And if you put a small r here, ideally we have to write like that: small r, then capital R3. Then this small r will stand for real-time reverse transcriptase PCR. Okay. Here this is a quantitative reverse transcriptase PCR. So here the target they were looking at is E gene and N gene, but here in the here again you can look at N and other activities. Sample is okay. Here you see you need more copies. This is the one I think the even though Srijitra was claiming that they are detecting from a lower copy, but the data from outside are showing you need a more copies, a more viral load to detect such in LAM technique. So this is again the assay time is even less. It can be different methods are there. One method which I've already discussed before, the ID platform or like ID now, where you can get a positive results in 8 minutes and a negative results in 15 minutes. The main problem here is it is always qualitative, but in an RT-PCR, like in an RRT-PCR, it is quantitative. Looking at a cycle value, even though you will not get a correct idea about what is the log or the viral load, still you will may get a good interpretation of that. And this is not a bulky instrument, and again, you need an approval for that. So basically, this is a qualitative test, and the other one is a quantitative test. But this is relatively quicker, so you will get a like faster results. And this is again other issues. This is other lamp I've already told. Same, the qualitative, quantitative, same picture only. So here what they are doing is you take an nasopharyngeal swab, you put it in the extracted viral RNA, you take it an extracted viral RNA, then they will be using something called an isothermal amplification. So this is the method used here in the lab technique and again in the ID platform. This is called an isothermal amplification. So in the isothermal amplifications, here you can see this Cas12 complex with the SARS-CoV-2 gRNAs, and again the target recognition and probe cleavage, and finally you can see a lateral flow visual readout. So this is basically a flow visual readout, which this is the time taken. But here this part, I think the technique in lab technique used in Kerala, they have significantly cut down the timing here. That is why we are getting a quicker results. And the abort technique is very quick. That takes only 8 minutes for the negative and 12 minutes for the, sorry, 8 minutes for the positive and 12 minutes for the negative. The symptoms and all, just to review once again, the primary mode of transmission is droplet. Always keep in mind, the may be aerosolized. We still feel that there is an aerosolized, but still the main mode of transmission is droplet. That is why we are making the every person to wear the mask to prevent the droplet spread. The symptoms like fever, dry cough, fatigue, sputum production, dyspnea, myalgia, sore throat, headache, anosmia, all those features are there. So initially you will be having a viral response, then followed by a symptomatic infection, then there is a hyper inflammation where the patient will be in the severe phase, then we will be going to a critical phase, or some of the patient at this point may recover, or the majority of the patients will recover in the initial phase itself, or even an asymptomatic patients also can recover. This is a usual course. And this is different mechanisms, like the convalescence plasma will be having a antibody, so it can bind with the like viral particles and can save the persons. This is again the neutralizing antibodies getting bind to the like virus, and it can definitely make an immunomodulatory effects as well by reducing all these interleukin levels. Now, again, going back to the persistent viremia or the persistent RNA positivity, I've already shown this slide last time. Initially, the patient can have fever, then followed by cough, then later on patient can develop dyspnea. This is again very, very important finding, because yesterday I received a patient in my ICU. The patient was treated outside in a COVID hospital, was kept at that hospital for almost 10 days, tested twice. It was negative, but again patient had recurrence and came to our unit. But while taking the history, it is obvious that the symptoms started with an exertional dyspnea for almost 2 weeks. It was gradually progressing. Then the patient started developing cough, other symptoms. So when you start with an exertional dyspnea initially, always think about some structural lung disease like an interstitial pneumonia. So probably my patient was having an interstitial pneumonia. So that's it. That is a history taking this point is very, very important. Again, in non-survivors also, you can see the dyspnea was developing later. These are the like two groups of reported patients. And here you can see the RNA positivity can last up to 20 days even in survivors. This is average. I told up to 58 can be positive. Here again, you can see even in death patients, it may extend up to the patients are dying. And today there was a discussion about the death in Manjeri. So that is why I am putting this again. So here you can see the pre-symptomatic itself, the symptom onset, the pre-symptomatic time onwards, there can be a spread, and the majority of the time the spread is in the pre-symptomatic period. So here if you compare the spread, this is the like pre-symptom, this is from the initially after the incubation, the symptomatic onset. The symptom can start from here itself. Sorry, the spreading. So the spreading can happen from the pre-symptomatic phase itself. This was not there with the SARS. It was there with influenza, but minimal. But this is more than a seasonal influenza. We have symptoms. So now we can have, like, if you take 100% of the patients, we can have a subgroup with no symptoms, other group with mild symptoms, then we have severe symptoms and critical symptoms. So the no symptoms group, they will be having an asymptomatic phase here, followed by an immunological response. Okay, initially they will be asymptomatic, later on they will be having an immunological response. So at this point, if you do an antibody response, you can detect an antibody positivity even though they are not having the symptoms. And the infectivity will be very short lasting. This is what has happened to the like Manjeri case, I guess, because the today's the death patient, his son has returned from Saudi. By this point, actually, after this infectivity, he that's last part of the infectivity period, he might have infected his father. He became sick. Then retrospectively, you analyzed and started doing a PCR for his son. So you may be doing the PCR at this point. You may be doing a PCR at this point. So obviously, by this time, his viremic phase has already gone. So he may be having a antibody at this point. So without doing an antibody, you may not be able to say that this person is not the cause of like infection for the his father. Okay, very clear. An asymptomatic person, you may get an like positivity in the initial days only. Later on, to retrospectively to say that these persons were not having infections, definitely you will have to do a PCR test. Now we have a moderate group with again initial asymptomatic phase, then a mild symptoms, followed by an immunological phase. So this is the like 55% of the patients will be like that with only mild symptoms. So here also you will be having a slightly prolonged RNA positivity and infectivity. So even in the asymptomatic phase to with the mild symptoms, they can continue to have positivity here. So the majority of the patients who are getting detected, like today also two Dubai returned persons are detected. I think they all belong to this group of persons where they may be having a very mild cough or like sore throat, which may be like undetected. And now when you are retrospectively checking or when you are screening them, you are positive, like detecting the positivity at this point. Okay. So maybe like if you have not checked it, maybe after few days if you are checking, you might have got a serology positive. In severely ill patients also, you can see initially you will be having the mild symptoms, then moderate symptoms, then they can go into severe disease and ultimately recovering, and they will be having a prolonged positivity. So as the disease severity advances, the chances of persistent positivity also will be more. The same way, a very sick patients, there will be like a critical illness, then progressing, then developing into the severe illness, then ultimately they will also become immune, and half of these patients also will die also. So here again you can have a persistent viremic phase. So this is the same thing again, which we have shown many times. Initially, you will be having a viral response phase, followed by a host inflammatory response, and this is how the things progresses. Only in the viral response phase, the patient will be having symptoms, which we have already discussed. I will not discuss that again. So this is how the symptoms are progressing. You can see this is the pre-symptomatic phase where you will be having a high chances of spread. You can see when you take an R naught value of 2, almost 50% or like almost more than 45% of the cases it will be in the pre-symptomatic phase. So the majority of the spread is occurring in the pre-symptomatic phase, followed by about for like 40% in the symptomatic phase, the 10% in the environmental, and it is 5% only asymptomatic. So asymptomatic is not a huge issue at all. This is only 5% of the spread, basically because they have very low viral load, and by universal masking you can completely prevent this group, and you can significantly cut down the pre-symptomatic phase as well. So by universal masking we are aiming to cut the transmission at the asymptomatic phase and the pre-symptomatic phase. So once again, the 45% of the patients are the spread occurs in the pre-symptomatic phase. This again the same repetition. You can see the nasopharyngeal swab and oropharyngeal swab. The CT value when it is going high, and when the correctly we may not be able to say it is viral load, but still we can say the CT values are high in nasopharyngeal swab. That means you will have to go with an nasopharyngeal swab. So those who are still continuing with oropharyngeal swab, please move on, like you shift to the nasopharyngeal swab. This is a real viral load where they have checked with the viral log, the culture copies. So this is the way exactly you have to look to see whether these viruses are live or not. So when you they did the log value in the viral load or the viral culture. You can see the copies here again in the severe disease and mild disease, which I was discussing before. You can see the severe disease is always having a higher viral load than the mild disease. The same way in the saliva, rectal swab, urine, etc., you can see the percentage of viral detection in severe percentage and mild percentage. So the severe disease or those who are landing up in the ICU, they will be having a higher viral load. And this is the mild disease or asymptomatic will be having a very, very low viral load. So once again, to stress that. And this I have already shown you many, many times, but still I am stressing upon this thing. Any patient admitted with COVID should have a pulse oximeter and continuously monitored. Otherwise, you are likely to miss hypoxemia. Majority of the patient may be absolutely comfortable even at a saturation value of 80 or even less. So the pulse oximeter is compulsory for all the patients, and oxygen target is always like you keep it between more than 90. Never try to hyperoxygenate more than 96. And when you have to the saturation is falling 92, less than 92, you can supplement the oxygen. And this is how you categorize, like in the room air more than 96 is always a mild, and again like less than 90 is severe. You will have to admit it in the COVID hospital. This is again, as the hypoxemia worsens, the chances of mortality is also more. And this is another mask which you can use, a non-rebreathing mask. So those anybody like who are listening, and if you're working in a COVID hospital, make sure that you have enough non-rebreathing mask. You can get a saturation up to 80 to 90 percentage with a non-rebreathing mask with a really good flow. So thank you so much. So this is my email ID. So if you have any doubt or something, you can directly mail me. This is my WhatsApp number. You can note down that. Or if you have any like queries regarding the COVID management or something related to that, if it is a topic known to me, I will try to like answer your queries. So please feel free to contact me 9961085558, or this is my mail ID. If you need any articles or any other materials for any presentations or something, you can contact me through mail. So thank you so much. After Ajay's presentation, I'll take the questions. Thank you so much. So Ajay is our pediatric intensivist. You may not have heard much about pediatric intensive care group. So now, just like in adult critical care, the sick patients in the pediatrics department that are taken care by intensivists. In Baby Memorial Hospital, we have two pediatric qualified intensivists, Dr. Ajay and Dr. Rauf. So in the coming session, Dr. Rauf also will be joining. So today, the Ajay will be describing about the pediatric COVID management, especially in terms of emergency and critical care.
Thank you, Dr. Anoop. So, good evening, everyone. So, I'll be dealing about pediatric COVID, mainly the basic emergency and critical care, what we can do. So, my scope of discussion will be, we'll be discussing about basic triaging protocols, especially from a private hospital perspective, handling of pediatric COVID emergency. We'll do a case scenario on how to do a COVID intubation, stabilization, transport, and how to do decontamination. What are the common pitfalls anticipated in each situations? We'll touch upon ventilation of pediatric COVID patients, how the lung is different, and we'll do a cardiac arrest scenario also. So I would like to start with a disclaimer. The recommendations or guidance are changing every day from time to time. So whatever is latest, we have tried to present at present. So at present, we should follow the state guidelines unless the government asks the private hospitals to start taking in more COVID cases. And many of the simulation scenes we have not taken in full PPE. This is because we wanted to conserve our stock of PPE. So kindly excuse us, please. So before starting, I would like to thank all my friends and colleagues in government health sector, especially who has been at the forefront in this war and helped contain this pandemic within the limits so far. Thank you, everyone. But we are not, even though it seems we have flattened the curve, it's not time for us to relax because we are still in India, and as you can see around us, the cases are still going up. So, right, because we were prepared from the government side and from the health ministry, we could contain in our state. So luck favors only the prepared ones. So we should be still not be letting our guard down and make sure that we are prepared even if we get a sick case. So I would like to start with how do we do triaging in our emergency when we get a pediatric case. Basically, in COVID triage, we will consider into whether it is a non-sick child or a sick child. If it is a non-sick child, we'll be triaging the child to the ER doctor, who will be wearing a PPE and examining him by a questionnaire. So based on that, he will make a decision whether to go for home care, or we can send to pediatric OPD to our consultants, or child can be sent to isolation room in the hospital or in the isolation room at home, or plus or minus testing. If it is a sick child, we may have to classify it as a non-respiratory emergency and respiratory emergency or resuscitation cases. Both these, that is respiratory emergency and resuscitation cases, we need to take inside a negative pressure isolation room. But the non-respiratory emergency, like the traumatic brain injury, fall from height, we can relax a bit. We need not take inside negative pressure isolation room, but still we have to take precautions if we are suspecting community transmission in our area. So going to epidemiology, as you know, the pediatric cases are very less compared to adults. The data from China showed only 2% of cases, while from USA, it had shown 5% of cases. So this is the pediatric and data from China and USA. The China had only 2,200 cases, out of which 13 were critically ill and only 1 death. In the USA, they had 20 ventilated cases and 3 deaths. But generally, as you know, the children, it is less severe, less symptomatic. They have decreased hospitalization and mortality. So these are the symptoms like Dr. Anoop had shown previously. The same with kids. They have fever, cough, fatigue, rhinorrhea, diarrhea, vomiting, and dyspnea. And if you look at the signs, they can have tachycardia, tachypnea. Lymphopenia may or may not be there. As you see, only 3.5 cases had lymphopenia in children. This is a study from China. And especially in children, only 6% were critically ill. Remaining 94% were either asymptomatic, mild, or moderately sick. So that is something we can be happy about. So going on, I will start with a case scenario, how we can handle a child when the child come to our emergency. So if you got a 12-year-old boy, we can call him Master C, with a weight of 40 kg. So family has just come from Maharashtra. So as you know, Maharashtra is a hub for community transmission at present. So the child developed fever and cough of 3 days duration. He took some oral medications by telephonic consultation. He developed sudden onset of breathlessness today. He was referred from a peripheral hospital with distress and desaturation. So questions are, how will we triage him? What are the precautions to be taken while triaging and examining? What are the next steps? So like we go back to the triage once. He's a sick child and he's in respiratory emergency. So we will take him into a negative pressure isolation room for examining, and we'll go with the initial assessments. We'll be looking at A, B, C, that is appearance, work of breathing, and circulation. So negative pressure isolation room, ideally we mean that we should have a good air exchange. So the AC will give the air inside, and there should be a mechanism to take the air outside with higher air exchange, more than 12. So what we can do in our scenario, we can put some exhaust fan and make it into a negative pressure isolation room. So in this child, going back, the child is sick looking, tired. So increased work of breathing, he has mild pallor. So definitely he is a sick child. So what will be our next step? Like Dr. Anoop told previously, it's always better to start non-rebreathing mask at 12 to 15 liters, especially if the child is very critically ill. And we can put a 3-layer mask over this, mainly to prevent droplet spread. So this is to prevent the risk of aerosol generation. As you can see here, this is the non-rebreathing mask, and we have put a 3-layer mask over it, mainly to prevent the more than aerosol, it's a droplet which we can prevent. So again, we'll go with the clinical examination. The child looks very tired. He has increased work of breathing, nasal flaring is present, retractions are present. Respiratory rate of 40 per minute, heart rate of 120 per minute, BP 100/60. In the chest, there are bilateral crepitations ahead, and there is no wrong eye. The other systems look fairly okay, other than he is slightly on the delirious side. So before starting, NRM saturations were 80. So after NRM saturations improved to 85%, but there is no change in distress. There is gradual worsening of sensorium. So somebody has done an ABG, which is showing pH of 7.26, PCO2 of 60, PO2 of 60. So basically, it's a respiratory acidosis with some amount of metabolic acidosis also. So what will be our next step? As you know, in children, we can use either HFNC, which we use quite a lot in our viral pneumonia, or BiPAP for bigger children, or NAV using ventilator, or should we go for intubation? So these are the four steps which we can go ahead. So we'll go one by one, do a critical analysis. So on HFNC, HFNC is very easy to use. The good thing is that the aerosol generation is slightly less compared to BiPAP or other NAV. And what we can do is we can put the 3-layer mask over the NAV machine to prevent further droplet generation, or we can keep the patient in a hood box or in the aerosol box, generally to prevent the aerosol generation and protecting our healthcare workers. And all the healthcare workers who are handling this case in the ICU, they should be in full PPE with N95 mask. So that is a good thing at HFNC, but in children with borderline respiratory failure, HFNC may fail. So this is BiPAP, which we generally use in kids who are slightly older. But the problem with BiPAP is they have a expiratory port. These are the vented mask. So what we can do is we can modify the BiPAP, use a closed mask, put a viral filter between the mask and the expiratory port. Still, there is a risk of aerosol generation with BiPAP because the mask may not be very tight. You can have aerosol from the sides. And especially in kids who may not stay fully sedated, BiPAP may not be a good indication. The other thing is a ventilator NIV. It's the same mechanism, but it's given through a ventilator. We have a dual limb. So there is no aerosol expired outside other than the one which can leak through the side of the mask. So mask should be very tight, and make sure there is a viral filter between the mask and the tubing, and the two viral filters in the inspiratory as well as the expiratory limbs. Always make sure use humidifier for children. But for this kit, probably we may have to go for indication, because if you look at the indications for intubation, if the PF ratio is less than 300, that is PO2 by FA2 ratio, the SPO2 FA2 ratio, that is SF ratio, if it is less than 200, if there is a worsening of respiratory distress or multi-organ dysfunction. So these are indications for intubation. So our kit has a PO2 of 60. So our PF comes to around 60 by around 80. So anyway, less than 300. So that means its child is an indication for intubation. So again, just going back, the how to manage hypoxic failure, we can try nasal cannula if the child is very stable. But in this child, we have to go by non-rebreathing mask. And especially our master C, we may have to go for early intubation. So how do we intubate? Like I said, we need to intubate in a negative pressure isolation room. But what are the other things we should consider? We should limit the people to only 3. We only try to limit to minimum 3 people. We should have an airway operator who is very skilled in pediatric intubation. There should be airway assist, and there is a medication nurse. And always make sure the equipments are kept ready. The medications are fully loaded, named, and labeled. Keep a backup person outside in case we anticipate a difficult airway. And how do we intubate? What are the medications for intubation? So mainly we have to give analgesia and sedation and paralysis. Analgesia and sedation, we can give either midazolam. It's a 40 kg child. We can give 4 mg of midazolam and give 20 microgram of fentanyl, stat, and assess the amount of sedation. If he's fully sedated, go for paralysis. If he's not fully sedated, again give one more small dose of fentanyl, 20 microgram, reassess. If he's fully sedated, go for paralysis. The paralysis should be very good amount of paralysis. We can give vecuronium, 4 mg of vecuronium, and this is mainly to prevent the patient should be completely knocked off when we're doing intubation, because there should not be any cough during the process of intubation. We can also give an atropine 0.02 mg per kg to decrease the secretions. So this is a schematic diagram which is showing how the fluorescent dye is expelled on the face of a person who is doing laryngoscope when the patient is coughing. So this is the main reason why we should have a completely paralyzed and sedate patient. And especially what there is, avoid bagging as far as possible. But like in children, their ventilation reserve is the lung reserve is very poor. So we may end up bagging in children, unlike in adults. So what we can do, the airway operator has to hold the mask in a VE technique. The mask should be completely fitting. There should not be any leak. And the other person can do the ambu bag. We can do the entire process either inside a plastic sheet, which is fully covered, or we can do in an aerosol box, whichever is convenient for us. And both the person should be in full PP and N95. And the small change which we need to make in the ambu bag, we need to put a viral filter between the mask and the ambu bag. And the most trained person should be doing the intubation, and intubation has to be done under the plastic cover or aerosol box. And immediately after intubation, we should do two things. That is, one is to inflate the ET cuff very fast so as to prevent any aerosol generation, and clamp the ET tube with a artery forceps. This is to prevent the aerosol generation, and also make sure you have a portable ventilator, because you can prevent you can avoid the bagging of the patient. And in the portable ventilator, make sure the HME is connected, HME or a viral filter is connected in the expiratory part. This is to protect the ventilator. The patient is connected to the ventilator, and the next step, either we can go confirm whether he's a COVID case, either by sending a swab from here or in the ICU. So in the ER, if you're sending the swab, try to send a nasopharyngeal swab and try to avoid sending an endotracheal tube swab, though the endotracheal tube swab is can give much more yield. So what are the tests? Basically, we are looking at the viral PCR. We don't do antigen, or at present, we are not doing antibodies in our setup. And this is a diagram I think many of you might have seen. So basically, we are looking at three target genes. One is the RDRP gene, envelope gene, and the N gene. So I'll just mention about the type of PCR test. One is the RT, that is reverse transcriptase PCR, which are there in many hospitals, government hospitals and private hospitals, where they check for all three genes. And there are two more tests which are sanctioned by ICMR and Kerala government, that is Gene Expert and TrueNut. The Gene Expert, they look at N gene and E gene, and TrueNut, they look at E gene. So this is how you conclude the Gene Expert result. If you have an N gene positivity, you can N gene and E gene both are positive, it is positive. Even if N gene only is positive, it is confirmed positive. But if it is only E gene, that is only presumptive positive. So this is what Kerala government has told. They had taken Gene Expert as a confirmatory test, and TrueNut is a screening test. If it is positive, we need to confirm by doing a RT-PCR or a Gene Expert. But one thing we should keep in mind, if you're doing a RT-PCR, the first 7 days, the 67% chance, it comes down by 39 days. There is gradually the RT-PCR yield sensitivity may come down. So going back to our case, next we'll be doing the transportation of the case from the ER to the ICU. So we should use minimal personals for transport. So that's why we avoid bagging, put the patient on a transport ventilator. We should have a designated pathway of transport. And immediately after intubation, the room where we intubated has to be cleaned with 1% sodium hypochlorite. It should be done within a span of 20 minutes. The contact period of the sodium hypochlorite should be about 10 minutes. And this is a WHO diagram on how to do the decontamination of the room so that we do not miss anything. So all the reusable items we can clean with 70% isopropyl alcohol and send for ETO. The disposable things can be disposed. So where to ship the patient? It varies by institutions as per their policies. So it's always better to cohort patients into COVID suspected or confirmed ICUs. So because the pediatric cases are less, we may have to keep the pediatric case and adult suspected cases together so as to prevent to keep our staffs minimally exposed with the COVID patients. And always use negative pressure isolation room. If it is not available, use single rooms with separate exhaust. And there should be ICU admission criteria. That is, patient with severe pneumonia, the severe respiratory distress or SpO2 less than 90%, the ARDS patients, the patient with sepsis or septic shock, any COVID-19 patients with any other life-threatening conditions. So this is a basic ventilatory circuit. As you can see, we have two filters. One is the viral HME filter, which is close by to the patient, and there is a viral filter in the expiratory limb of the ventilator. This is to prevent the viral particles from going into the ventilator. And also, as you can see, this is the viral filter. There is a closed section. You should not do open section in these patients. Always do closed section. This is a closed section tube which is connected to the ET tube of the ventilator. So ventilatory setting, especially in pediatrics, we prefer to use PRVC or pressure control mode and use low tidal volume 4 to 6 ml per kg. And PEEP of we can go from 5 to 15 depending on the type of lung, which we'll be discussing later, and the severity of ARDS. Always make sure the alarms are set. The PIP, that is a peak inspiratory pressure, should be around 30 to 35. We have IA ratio should be set 1:2. So ours is a 40 kg child. So we have got a tidal volume of 240, FA2 of 60, PEEP of 7, then rate of 25, IA ratio 1:2. So what are our targets? We'll be doing a gas ABG immediately, and we'll be targeting SpO2 of 88 to 94%. Probably in COVID pneumonia, we may target little more. We may target more than 90. The ABG, we'll be looking at PaO2, that is, and PaO2 FI2 ratio or oxygenation index, etc. Also, we'll be looking at the lung mechanics, looking at the compliance. Compliance is nothing but how the lung is expanding. So what do we do if the SpO2 doesn't improve? We look at the compliance. This is the compliance. We look at the pressure volume loop. As you can see here, the graph looks very straight. That means we have got a very good compliance. But suppose if the graph is showing a very flat loop, that means the compliance is very poor. So right now we have got a good compliance. So how do we proceed further? So for that, you need to understand something about the types of lung. The COVID ARDS, it's not a classical ARDS which we see. It's something different. What Gattiloni from Italy, what he has proposed a two-type model for the lung. So conventionally, what we do is in ARDS, we increase the PEEP. Increase the PEEP gradually to get a good oxygenation. But what he has found out is there are two types. One is type L and type H lung. Type L means everything is low. It is low elastance. That is, if the compliance is normal or high. It's a low V by Q. V by Q is nothing but ventilation perfusion ratio. There is low recruitability. There is no benefit in giving good PEEP. So in 70% of the cases with COVID pneumonia, it fitted into type L type of phenotype. As you can see, this is a CT film. There are some interstitial edema, but the majority of the lung is very well aerated. Unlike this CT, this is H type, where the majority of the lung is consolidated. So this is like our routine ARDS cases where there is low compliance. That means high elastance. There is a high right to left shunt, and these patients are highly recruitable. You increase the PEEP, the patient may improve. These are found only in 30% of the cases. So initially, all patients will start by type L. They may progress to type H. So in type L, they don't benefit from PEEP. So we can increase the tidal volume from 4 to 8 ml per kg. I'll be touching on it later. We can also increase FiO2. And type H, they do benefit from giving a PEEP. We can do the PEEP titration. So coming to L phenotype. So as you can see, in the L phenotype, the alveolar compliance is normal. They got a normal tidal volume, but there is some moderate level of subpleural interstitial edema. So what happens in COVID-19? There is something called vasoplegia. Vasoplegia means there is increased pulmonary blood flow. Usually what happens when the oxygen is less, the blood flow is decreased in all cases of pneumonia. But especially in COVID pneumonia, the blood flow, that is pulmonary blood flow, increases. So blood flow is nothing but V by Q is the ventilation perfusion. So our V is normal, that is the tidal volume is normal, but our perfusion is very high. So that means we have got a very low V by Q. So what the patient tries? The patient tries to optimize the ventilation perfusion. So he tries to expire and inspire more. He tries to increase his tidal volume. So the dyspnea gradually increases. That's why all these patients are initially hypoxemic. Later they develop dyspnea. That's what Dr. Anoop was stressing. So dyspnea may come later when the patient tries to do the compensatory mechanism. So, but what is the problem with doing this amount of increasing tidal volume? So they can be rapid, because here you can see the patient will try to, the diaphragm may try to pull in the lung, and all the muscles may contract. So there can be rapid swings in the pressure. So it goes something called PSLILE, that is patient self-induced lung injury. This is a basic pathophysiology which happens in the COVID pneumonia. So how do you identify the lung phenotype? So before intubation, it's very difficult to identify. Probably you can look at L phenotype. There may not be any dyspnea. Saturations may be more than 90%. After starting oxygen, the saturations may improve. The CT or X-ray, if you take, there can be some subpleural ground glass opacities. So in these patients, if they are hypoxemic with no distress, you give FiO2, you give oxygen. If they are hypoxemic with distress, you can start non-invasive ventilation with good amount of sedation. And H phenotype is nothing but our conventional ARDS. You can increase the PEEP. So after intubation, like we saw earlier, it is very easy to identify these people. The L phenotype, look at the complaints. They'll be having good complaints. Their pressures are very low. That is, if you give just 240 ml, the patient may not need that much pressure to give 240 ml. And L phenotype, the compliance is very poor and they got high pressure. This is our conventional ARDS. These will benefit by giving good amount of PEEP. So especially the L phenotype, if the PCO2, usually we need to completely sedate and paralyze the child on ventilator. Anticipate more than 2 to 3 weeks of ventilation. So give good amount of paralysis. In spite of that, if the PCO2 is going up, we can increase the tidal volume, because these lungs are not fully damaged. If you increase the tidal volume, it may not create too much of damage. So going back to the basic investigations which we can do, we can do the complete blood count, lymphopenia only in 3 to 4%, and also do the ABG, do LFT, look for transaminases in 15%, RFT electrolytes. We can look for the elevated CRP and procalcitonin, the severity markers of D-dimer, LDH, and ferritin. These indicates any features of cytokine storm. So also it's tropi, that is troponin I is very important in these children, because they can have myocarditis, also do blood culture and other workups as per individual scenario. And already we have sent the throat swab. So if it has not been sent, it has to be sent immediately. Chest X-ray or CT are not recommended as a routine for children. We can go with because we need to prevent exposures every time, and we can do a point of care ultrasound in COVID patients as a daily routine to look at any increase in the consolidation, any B lines or A lines, which shows increasing the fluid in the lungs. Suppose we are having high refractory hypoxemia, that is, if the PF result, PA to FI ratio is less than 150, we can consider proning. Proning is keep the you get to keep the child prone, keep it for 12 to 16 hours a day. So after 6 to 16 hours, make the child supine again. If the PA to FI ratio is more than 150 for more than 4 hours, you need not prone again. And also think about other supportive care. We need to have a strict input-output chart, fluid restrictions, and avoid positive fluid balance. Always use closed ET section like I have shown previously. Don't give any nebulizations on ventilator patients. Start early enteral feeding, early tube feeding. IV antibiotics depending on if we are suspecting a secondary infection. Avoid NSAID. Avoid high dose steroids, because steroids can prolong the viremia and it is found with increased mortality. There are no studies supporting steroids as a treatment of COVID-19 pneumonia. The early organ support, including hemodialysis, may have to be started. So what are the antiviral medications which can be given in pediatric COVID? There is no definitive therapy till date has proven any benefit. So all the drugs are based on clinical trial basis. We can give lopinavir, ritonavir with medical board permission. And this is one which we use, that is hydroxychloroquine and azithromycin. These are found to have some reduction in viral load in some studies. And other options are interferon, IVIG, and convalescent plasma from recovered patients. So hydroxychloroquine, this is the Kerala protocol given by SAT. That is, these are mainly in symptomatic COVID patients requiring hospitalization. So we can give hydroxychloroquine, that is 6.5 mg per kg per dose on first day, twice daily, maximum 400 mg, followed by 3.5 mg per kg twice daily, maximum 200 mg for 4 days. This can be combined with azithromycin, 10 mg per kg, maximum 500 mg, followed by 5 mg per kg for 2 to 5 days. Suppose if you are suspecting in a cytokine storm, we can try tocilizumab, which has been discussed earlier. So any features of cytokine storm, like any doubling of ferritin and high D-dimer, and there are H-score or criteria which gives us a clue regarding cytokine storm. In this condition, we can try tocilizumab, but cost is a factor which can prevent us. So these are the places where the drugs act. This is the hydroxychloroquine, which inhibits the viral entry. And azithromycin is not shown here, but azithromycin has a immunomodulatory action, and it has a synergistic action with hydroxychloroquine. So that is the use of azithromycin. And lopinavir, ritonavir, it inhibits the proteolysis. And this is a newer drug, that is remdesivir, which is done in a clinical trial basis. The trial is called Solidarity trial. So it inhibits the RNA-dependent RNA polymerase. And this is tocilizumab, which is binding on the IL-6 receptor. So this is how tocilizumab acts in the cytokine storm. This is the coronavirus affecting the macrophage, dendritic cells, and monocytes, which leads to cytokine storm. So how do we wean and extubate? Always anticipate prolonged duration for all the ventilator case, more than 2 to 3 weeks. So basically, if the PaO2 and FiO2 ratio is more than 300, we can think of stopping the sedation after good weaning, and extubate the patient only if the patient is fully fit for extubation, because we want to avoid non-invasive ventilation as much as possible, because it is an aerosol generation procedure. So try to avoid that. There are different methods which are used by different institutes. Some tried a plastic bag which is inflated with oxygen during the process of extubation. And this is a Chinese people who used a disposable bedspread to avoid any droplet spread during extubation. So just finishing something about ECMO in COVID ARDS. ECMO is not something which is ideal for the scenario. This is a small study from China. They have put 30 people on ECMO. So 5 people they could wean off successfully. The 6 people still on ECMO more than 3 to 6 weeks, and the remaining people expired. So ECMO is not a therapy to be rushed in a pandemic with limited resources, especially in countries like ours, where more lives can be saved by giving oxygen and a simple pulse oximetry. So just briefly about COVID, it is like any other septic shock. You use crystalloids over colloids. Always use adrenaline as a first line vasoactive agent, and titrate the mean arterial pressure of more than 55 plus 1.5 times age. And always think of starting dobutamine, especially if you're suspecting any myocardial any dysfunction. In refractory shock, there is an indication for using low dose corticosteroid as a only in refractory shocks. So suppose if the child has a CPR in the ICU, so what BLS, that is basic life support, says there is some changes. Don't listen or feel for breath. There is no mouth to mouth breath happening. And in always we should limit the number of people inside the negative pressure room, and try to intubate if the patient is not intubated, try to intubate the patient early. And even if intubated, try to avoid bagging. You can increase the rate on ventilator Try to avoid bagging. If you need to bag, you bag with a good amount of filter seal and sealing. And just a few words about infection control and practice. Always in the ICU, always use full PPE using N95 mask, especially in the cases of aerosol generation procedures. Always make sure the disinfection of high-touch surfaces like monitors, ventilator screen are done every 4 hours. Surface decontamination by isopropyl alcohol, disinfection by 1% sodium hypochlorite. And this is very important. Always try to keep a social distancing in the ICU and prevent contact and always do contact and droplet precautions. So this is basically what I need to say about pediatric emergency and critical care. So these are difficult times for all of us, but all this will pass. It might pass like a kidney stone, but we will overcome surely. Thank you.
So now we'll move on to questions, Ajay. So Shaji sir has asked about steroid use in these cases. Uh, if so, what steroid? You want me to take or?
I think Sari is asking about that study, tocilizumab study.
Okay, so in the steroid, actually, the many dose steroids were used. Majority of the studies are with methylprednisolone only. 1 to 2 mg per kg is the dose used for the methylprednisolone. But even though like surviving sepsis guideline recommends steroid in ARDS, COVID ARDS, it is not well accepted because even in ARDS, the role of steroid is still questionable. But it is true when the patient is having a cytokine storm or the features of macrophage activation syndrome, we can go with the 1 to 2 mg per kg. Then if it is not responding, obviously we'll have to think about tocilizumab. Then next question is about LAMP and LAMP technique over the other results. Other than fast results, is having any other advantage? No. This is basically fast results, and again, I've already told you the machine is very small. You don't need any the expertise like an RT-PCR. You will get a faster result. Disadvantage being is always qualitative. You will not get a quantitative result. Other than that advantage, only the time the advantage is there, and obviously the cost per test also will be less when you compare with a uh, normal test. Age distribution of tocilizumab, I will have to go back and check that again. I didn't see that in detail that much regarding at what age they were utilizing. Chikupol,
But ECMO and when to go for ECMO. Actually, like I said, ECMO indication it's not a good mode to trial in our resource limited setup. So
no,
usually we anticipate a ventilator
ideally in
around
any, yeah, any ARDS, the ECMO we look at PF ratio. When the PF ratio is somewhere around 50, you can go. But obviously in the COVID new ARDS, the outcome is not that good, so it may not be advisable to go for an ECMO.
one.
About the availability in Calicut City, I think 2 or 3 hospitals are already having ECMO, including Baby Memorial Hospital. Explain once again today's Manjeri case. So today's Manjeri case is like they have already issued a treatment note about that. He was a 80 plus year old man admitted with pneumonia. Again, PCR was positive, retrospectively analyzed. So his son has returned from Dubai, but the PCR test has come negative. I've already explained the reason for that. If you are doing a PCR test in a mildly symptomatic or an asymptomatic patients, by the time he spread the disease to second person, he will be developing pneumonia after a week time. So obviously there is a gap. By that time, he will be PCR negative. So unless and until you do a serology in his son, you may not be able to say his son is not the person who was spreading the disease to him. Then later on, he improved. They did PCR twice. These all reports I got it from their medical report shared by the treating team. Actually, the doctor who was treating as Srinivas Babu, he has forwarded me that message. This is the information I got through that message. I didn't talk to Srinivas also. So then he was shifted to the out of ICU where he developed a acute myocardial infarction. Before that, two tests were negative. He had went into renal failure also. Later on, ventilated. They again got opinion from cardiology team, nephro team, etc. But he continued to be sick with poor cardiac function and renal parameters. And I think they have dialyzed also, and he died after that. So his test was negative, and probably by analyzing all those things, the cause of death is likely to be a cardiac event, and obviously the age-related issues. Maybe this is all precipitated by a COVID illness, but it is not directly related to that. His son has already recovered. He was not having any much symptoms. That is what I understand. Immunity recovered. Is there any evidence for the development of immunity? No, there is an evidence that the immunity will develop. Antibodies are tested, but still we don't know how long this antibody will be persisting, and the persisting antibody is really protective. So these are the two things we still don't know. We will have to definitely we'll have to go for that. Uh,
And what is the, somebody asked the question, Dr. Ajit had asked the question, what is the lower stage for hydroxychloroquine? So ICMR, as a prophylaxis, ICMR had told not to give before age of 15 years. But for treatment, we can give even for infants. But problem is that you need to check the ECG. Make sure that the ECG, yeah, the QTC interval, corrected QTC interval, not more than 25% of the baseline. You may have to repeat the ECG again and again. So, which is the ideal weaning mode of ventilator? Dr. Yeldo had asked. So basically, will be putting the child on PRVC ventilator, and what they suggested is go to CPAP mode trial for maybe 1 or 2 hours, like we regularly do on any ventilator.
Yeah, CPAP pressure support what is really good. You don't need a SIMV. SIMV is not used nowadays. I'm not going into the detail about that. You start with a pressure control mode or a volume control mode. Both the modes are assist control modes where the patient can trigger. Then you switch over to a support mode or a spontaneous mode like CPAP pressure support. Then you can gradually wean down. Meaning the both types, like you might have listened, like Ajay was describing, there are two types. The one is like an L type with a near normal compliance, and a H type with a stiff lung. So when you have a normal compliant lung, you may have to use a higher FiO2. We will have to accept using even 100% of FiO2. As the patient improves, you start reducing the FiO2 and keep the PEEP somewhere around 5 to 7 only, or 5 to 8. Then as you reach somewhere around 40 and when the patient is comfortable, you can try extubating. In the other group, just like any ARDS, you recruit with higher and higher PEEP. You can use different methods to titrate the PEEP. Then gradually you reduce the PEEP and FiO2 as the PF ratios improves, and then we can try extubating. Then one thing like the Ajay in the video was showing, when one person was intubating, the other person was not in PPE. That
Yeah,
is because, yeah,
uh,
we
we are
don't
trying
wear
to
enough,
conserve
yeah,
the.
enough PPE in the hospital. That is why only one person was wearing the PPE. So please don't like carry away with a wrong message that one person will not be in PPE. Ideally, we should have three persons in a intubating room. One person for giving airway gadgets, other person for giving drugs, and a doctor who is intubating. And always, like a senior doctor should intubate. So only three persons, and one person can stand outside the room. We call it as a running nurse who can just coordinate the things from outside, or in case of an emergency, they can come inside. So they also should be in PPE. So ideally, we need four persons, two inside and one outside. And one more thing, Ajay was showing the after intubation, the patient was connected to a transport ventilator. So there also the patient was in an emergency room. I think you may be remembering that. He was explaining when you are intubating in an emergency room, and when while you are shifting, rather than using an ambu bag, you should always use a transport ventilator. But if you are intubating in an ICU, you connect to a normal ventilator. I think that is also very clear. So don't confuse at that point as well. Other thing like what I question I got in Facebook was regarding the negative pressure setting in an ICU, especially using a split AC. So split AC means you don't have to worry because you are not sucking in the air again. So you keep a split AC, along with that you keep an exhaust fan also, or like the air draining fan, whatever name you call it for that. So once you keep an exhaust fan, obviously the air will be sucked out. So the negative pressure will be created inside the room. So that is the simplest way to make a negative pressure room, or like a negative pressure operation theater room as well. Majority of the operation theaters are positive pressure. You cannot operate on a COVID patients in a positive pressure room. Okay. Uh,
And I think one more question is how proning improves ventilation. So in, like I said, there are two phenotypes, L phenotype and H phenotype. The L phenotype, that is in the early phase, if you like oxygenation is only poor. Some people have found that just patients on just only oxygen or by nasal cannula, if they prone the patients, they found oxygenation to be better. That mechanism probably due to improvement in the ventilation perfusion mismatch. But that mechanism is not clear. But mainly in the H type, that is the conventional ARDS. So it is like any other ARDS which we regularly get. The proning helps mainly by it splinting up the airway. There are two or three mechanisms which helps. That is then the conventional ARDS mechanisms. But in the L-type phenotype, the mechanism is not fully clear. But in mainly the people who are managed in the Italy and USA, they found keeping the patient in prone position helps in ventilation.
So just to add on to what Ajay has already told, so the mechanism of proning, or the improvement or more recruitability with proning, it is just like with any ARDS, and there are three basic mechanisms are described for proning. One thing, as he was described, like there will be an offloading by the cardiac activity. So usually there will be heart will be pressing onto the lungs. So when you are proning, the offloading of cardiac the pressure to the lungs will help to improve the oxygenation. The second thing will be like while proning, the dorsal segment which are less like ventilated, so that will be ventilated in a better way when you are proning the patient. And the third mechanism will be the better toileting. So once you prone the patient, the toileting or the clearance of the secretions also will be better than in a supine way. So these are the three mechanisms described for improving oxygenation, like as a part of proning. And probably, I think you might have seen a video how to prone a patient. Dr. Mahesh in the BIMS, he has made a nice video. Probably in one of the sessions by ISCCM, we will be putting that video. He has made a nice video on intubation as well. Or you can contact Dr. Mahesh, he's the chief of critical care medicine in BIMS. He's having a nice video on how to prone that. Or in NEGM also, there are videos about that. And I think Ajay can also make one video on pediatric proning. We can try to do that. Any other questions? Smita has raised the hand. So Smita, where is she? Yeah. Smita, you can. Smita, you can ask now. Smita, can you hear me? Yeah.
Unmute. You need to unmute, I think.
Yeah. You will, yeah. Smita, you will have to unmute. Smita, you are muted from there. You will have to unmute. If you are using a mobile phone, like in the lower part, if you just touch it, you will see a microphone's emblem. Just push it on that. Or okay, maybe some by mistake they might have raised the hand. Any other questions? Any role for high flow nasal oxygen? We have already
High frequency
high frequency. Okay, HFO. Yeah, high
HFO.
frequency. Like
So
you can answer for that.
basically in adults they have not found any benefit like in ARDS also. But for pediatric cases, in ARDS cases we have found benefit, but we don't have a literature for COVID ARDS so far on high frequency.
There are two trials called Oscar and Oscillate. I think in 2018 we had those two trials. So those two trials did not show any benefit or mortality benefit with proning. So after that, in the adult group, we stopped doing high frequency. In 2000. 10 and all, when we had the influenza outbreak, that was regularly used. I think up to 2018 or 17, we were using that, but now it is not used after the two negative
Yeah,
trials.
but in pediatric, probably we may sometimes use. We have found benefit maybe on personal basis, but still the trials doesn't support HFOV.
Okay. Anything extra if you want to discuss, or again, if someone else want to discuss any points, you can just raise your hand. We will release you. Then after that, can have a discussion. Any person like in the attendees list, you can just raise the hand. So nothing, and the questions are also answered. So thank you so much. We have tried to Ajay has nicely covered all the topic uh, in related to a pediatric ICU care for COVID patient. It was an excellent presentation. Ajay really appreciate that. I think you can utilize this presentation for through IAP also to training people. So keep it up. Thank you so much, Ajay. And again, thank you everyone for listening. And we will be going for a short gap after this thing. So once we get a newer topics, we will be coming back again, maybe after a few days, which will announce through direct communication, and again through the web page and Facebook page of Baby Memorial Hospital. So thank you so much.